we've seen significant improvements in cancer survival over the past 1 to 2 decades. And primarily, we've seen this not only from reductions in smoking and earlier cancer detection, but advances in some of our treatments, most notably in the realm of immunotherapy and targeted therapy, particularly some of our small molecules and monoclonal antibodies.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. Today, we're talking with Suzanne Walker, Senior Advanced Practice Provider and Coordinator for Thoracic Malignancies at the Abramson Cancer Center at Penn Presbyterian Medical Center in Philadelphia, Pennsylvania, about the latest updates in chemotherapy and immunotherapy treatments that oncology nurses need to know. Suzanne is one of the editors of ONS's second edition of the Chemotherapy and Immunotherapy Guidelines and Recommendations for Practice book. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Suzanne.
Yes, thank you so much for having me here. I'm super excited to be here today.
Wonderful. Well, to start things off, can you give us just a brief overview of which areas of anti-neoplastic therapy you think have seen the biggest advancements?
So let me just start back in the beginning. So I've been in oncology nursing for over 30 years. And when I first started, we had just a handful of chemotherapy agents, and the prognosis was very bleak for many of our patients. But we've seen significant improvements in cancer survival over the past 1 to 2 decades. And primarily, we've seen this not only from reductions in smoking and earlier cancer detection, but advances in some of our treatments, most notably in the realm of immunotherapy and targeted therapy, particularly some of our small molecules and monoclonal antibodies.
I've been in practice for 16 years and counting, and echo the similarities that you've described of just how it used to really only be a handful of agents and all of similar type. They were all in that chemotherapy bucket, but how things have changed not only so dramatically, but so quickly in the past 5 years or even less. It's kind of awe-inspiring to me to think of like all of the hard, great work that our oncology nurses are doing to stay current and stay up to date on all of that.
Yes, it's very much exciting. And it's just been an honor to be a part of this whole process over the last 30 years.
So let's talk about what changes have you seen just regarding maybe the number of approvals and maybe the pace at which we're seeing these drug approvals come through the FDA, the U.S. Food and Drug Administration?
Yeah, so absolutely. So let's start off with a little bit of history here. Dating back to, I remember when I was an infusion nurse and we were doing trials on rituximab, and that was first approved. That was the first monoclonal antibody approved in 1997. And then subsequently, since then, we've seen trastuzumab or Herceptin for 1998. And then really what I think revolutionized the world of CML therapy was the introduction of imatinib or Gleevec in 2001. There was an interesting paper actually published this year that looked at approvals for cancer therapeutics basically since the year 2000, from 2000 to 2022. And they found there were 573 FDA approvals for over 200 distinct cancer therapies in that time. That was over a 700% increase in that period and over a 400% increase for distinct new drug approvals. And this is really just tremendous strides that we've made. Most notably, a lot of those approvals have been in certain cancers. So in my realm, I work primarily in the lung cancer space. So that's one of the areas where we've seen the most approvals in new therapeutics, lung cancer, also breast cancer, GU cancers, and lymphomas and leukemias.
Not only is it the volume of approvals and the speed at which we perceive the speed, obviously the ramp up and some of the distinctions and programs the FDA has developed to kind of move the process along quickly when it can be have helped, I'm sure. But I think just the speed at which we feel like new drugs are coming out it's almost overwhelming, especially for those nurses, I think, that are working in generalist practice, community-based settings where they maybe aren't subspecialized into one certain disease type or program. That can feel, I'm sure, even more overwhelming when each day it's a new drug for a new disease that you may or may not be seeing a patient for right now. And how do I compartmentalize and kind of put that information into a bucket that helps make sense? And not only that, but now we're seeing drugs that are first in class. So they have mechanisms of action that we've never seen before. And so trying to layer that information on top of what we already know or what information we do have just adds another layer of complexity. I've mentioned this before, I'm sure, but it once felt like, well, you could just pick a disease site and try to learn the therapies associated with that diagnosis to onboard a new nurse who's new to oncology. But that doesn't really work anymore because every drug could potentially be used for other disease sites. And so picking one, not only is the volume of drugs for that one disease or that one diagnosis huge, but it also, they don't necessarily just live with that one diagnosis anymore. And so the whole concept of how we teach new nurses oncology and how we ourselves stay up to date on oncology, I think has sort of been turned on its head. So it's been an interesting time.
Yes, absolutely. And I think you brought up a good point about not just focusing on the diagnosis as much anymore, as there have been some approvals for what we call agnostic approvals, meaning drugs have been approved not necessarily for a specific cancer type, but rather based on specific genomic profiling. So for example, in 2017, pembrolizumab has already been approved for other specific cancers, but it was approved for a more generic indication for patients who had tumors that were MSI or microsatellite instability high, or had a mismatch repair deficiency, an MMR deficiency. And so we definitely are seeing more of those agnostic approvals, and it has been a little bit overwhelming. I know even myself working in a really subspecialty area in oncology and thoracic oncology, even just to keep up with the number of therapeutics that we have now in this particular space, it is very challenging to sometimes keep up with all of that.
So just diving a little bit deeper into that, the concept of the targeted therapies, can you give us an overview of how the use of targeted therapies has grown in recent years?
I think a lot of that has to do with the explosion of biomarkers and what have been discovered in the realm of biomarkers. So this area of personalized medicine. So we have to kind of discover these biomarkers and what drives these tumors to grow and divide. Sometimes you may hear the terminology driver mutation. So what is making that individual's cancer grow and divide? And so I think we've definitely seen a real expansion of these biomarkers that have been discovered. And then with discovery of the biomarkers has brought around the discovery of genomic driven therapies that are specific to these biomarkers. That's really changed the landscape of oncology for people that have one of these driver mutations to have a therapy that's specifically targeted against that mutation. Whereas, in the past, when I first started, we were looking at generic chemotherapy, which targets all rapidly dividing cancer cells, whereas the targeted therapies are more specific. It's just really been an exciting time. When we think of targeted therapies, we think of sort of the monoclonal antibodies, and then also some of the small molecules like the tyrosine kinase inhibitors. And so I know in my lung cancer realm, there have been too many to count, even new targeted therapies that have been developed against a variety of molecular sort of these driver mutations. And it's a really exciting time to be in the field of oncology because we can have these, specific drugs that target these specific mutations rather than, back in the day when we had to really just use kind of generic therapies that weren't specific for an individual's cancer.
Yeah, I always think of, my subspecialty when I was in direct care was GYN oncology. And so we're now coming into the fold a little bit with some of this biomarker driven therapy with PARP inhibitors and certain immunotherapies. But you're right, lung cancer and thoracic cancer has really led the way in some of that work. And so I think what I've heard our nurses, and members tell us is just how that can influence and impact that upfront discussion you're having with patients if they are newly diagnosed, and helping them to understand that the process of learning all of the information we need to really set that treatment plan in motion can take a little bit longer now, because we really do need to get some of that upfront testing done, whether it's done in-house or if it's through a third-party vendor, but to get all of the biomarkers tested for. And so a comprehensive treatment plan can be made from the very beginning. So I think that's really also changed. As you said, it's not just histology. It's not what does this cell look like, but we have to understand the driver variations in that cancer cell to really guide the therapy accurately.
Yes, and I think you raised an excellent point about the testing and how we do have to explain to our patients that it might seem like forever that they're waiting to start treatment, but we really do want to often wait for the results of that molecular testing to come back so that we can develop the best treatment plan possible for that individual. And I think also along with that is the care that we're delivering has also shifted as well. Thinking about some of these targeted drugs, a lot of them are oral agents. So it's really kind of changed how we think about cancer therapeutic administration, whereas historically we've always thought about intravenous infusions being done within the practice suite. Now we have to think about sort of giving that control over to patients when they're taking the medication at home in an oral form and how that's being monitored, how we're monitoring for adherence as well as toxicities, reimbursement, financial concerns, and opens up a whole different set of issues that oncology nurses need to be aware of.
I definitely agree with you 100%. I would say in the most ideal circumstances, in the ideal clinic setup, it has created the need for a separate program in terms of oral adherence and helping patients manage not only obtaining their prescription, paying for it, if that becomes a concern, depending on what their insurance status is, using different specialty pharmacies, sometimes that are mandated by their payer. That becomes a whole issue on its own. And then, as you said, then we are at some point having to sit down with the patient, provide them with the education of how to give this treatment to themselves. And while certainly benefits include patient having autonomy, not stuck coming into infusion as often, there are some great positives with that, but certainly some risks, and that have to be balanced with ensuring patients really understand how to take their treatment accurately and when to report certain symptoms or side effects. And if there's accompanying lab work or other diagnostic tests that need to be done with some regularity, coordinating that really has become, in the clinic setting, sort of in that coordination of care realm, a distinct part of cancer care that we provide in the ambulatory setting.
Yes, absolutely. We have had to create separate teams for this, and it is just a different way of viewing it. And I think it does also have a lot of financial concerns, particularly with reimbursement, with intravenous chemos typically historically being covered through the medical side, and now the targeted oral therapies are often being covered through the pharmacy or prescription side, and those coverages are often very different. So I think that's an area that's still up for development.
Absolutely. And just all of the various ways, most, especially drugs that are still under patent, a lot of those companies do offer patient assistance programs and just ways to help mitigate some of that, what we now know and call financial toxicity. But just every patient has a different circumstance. And so what helps one patient be able to afford their medications can be something entirely different for another patient. And just the complexity of that conversation. And again, in the best programs and the ideal circumstance, there is hopefully a financial advocacy and navigation program that is kind of walking side by side with that patient to help them understand what coverage do they have, what shortfall needs to be made up somehow, and what are the programs, whether they're time-limited grants or different funds from different foundations, like I said, patient assistance programs. And so even that whole portion, which has nothing to do with clinical, it's almost entirely separate. Though I know many nurses find themselves in that position. It's just, again, it just highlights the complexity. And I would say the same is true probably for intravenous medications as these new drugs get developed and the sometimes very shocking price tag that is associated with them when you think of things like CAR T-cell, bispecifics, the newer drugs that are coming with a very hefty price tag, that the whole logistical piece that needs to happen behind the scenes before the patient even comes in terms of approval and getting things, all the boxes checked for that. It just has become an entirely separate part of the business of healthcare. And I think that adds complexity to the nurse's role, just ensuring that even if they're not the one doing that work on behalf of the patient, that they understand who can they go to in their institution, who is the person that they can refer them to. And then sometimes nurses are the ones still doing it. And so figuring out how to balance the needs of that process and those questions with some of the more clinically focused in terms of patient education and how to take your treatment on schedule and side effect management.
Yes, absolutely. I think there's a lot to be still continued in that realm.
So we talked a little bit about biomarker testing and how it's really become a necessity, a requirement for many diagnoses that have to have some biomarker testing before the treatment plan can be formed, just because so many frontline treatment regimens include these biomarker-driven targeted agents. Are there any other ways that you see that biomarker testing has influenced the development of new treatments for patients with cancer?
Well, I think it's been kind of the primary mechanism that we've seen that have driven development of these new therapies. I teach at our affiliated School of Nursing, and when I first started, we had no lectures for targeted therapies, and now we have actually 2 whole lectures devoted to targeted therapies in our oncology coursework. And each year, the table of available biomarkers gets larger and larger. So I think it really does help us kind of really with that precision, accuracy, trying to get to the best treatment plan possible for that individual. And, we really do rely on the biomarker testing, and there are different ways to go about obtaining it. And so we can obtain it either via tissue, which is preferred if possible, but sometimes tissue isn't always available through a biopsy. And sometimes it can take a while to get those tissue results back. But we could also do what's called a liquid biopsy, where a blood sample is taken and sent to usually an outside lab to be tested. We can do that in people who maybe don't have tissue available, or if we need to get some timely information on these biomarker results so that we can try to move treatment up in a quicker way.
Let's talk a little bit about the setting. We could start off with the physical, actual physical setting that, we're seeing with targeted therapies, immunotherapy agents. We've talked a little bit about already how many of the targeted agents are oral therapies. And so that moves that treatment at home. But are you seeing anything within the treatment landscape that hints that some of even maybe infusion therapies might be given in a different physical setting?
Yeah. And I think we saw this a lot during kind of the height of the pandemic, when we were trying to keep patients safe and out of the hospital setting or out of even our outpatient practices. And we were moving some of these intravenous therapies, such as some of the monoclonal antibodies and immunotherapy drugs, into the home infusion setting. We are actually kind of seeing that trend continue a little bit. And we're seeing some insurers actually kind of mandating that patients can't get the infusion in our outpatient office. They have to get it at home or through another avenue. So I think that's one thing where we've definitely seen some changes is, people maybe getting some of these infusions at home, the IV medications, and then certainly the oral ones, getting them at home and then kind of figuring out how to monitor them, when to bring them into the office. I think also telemedicine has helped us make significant strides. So for our patients who are on oral medications, we do have the flexibility now of perhaps letting them, they're self-administering at home, and we're able to monitor them via telemedicine if, they live a distance from us and can't come in just for a visit and some blood work. We're able to kind of manage things remotely with telemedicine. So I think between that and home administration, I think those are areas that we've seen a lot of growth, particularly since the pandemic.
I would agree 100%. And I think you bring up a great point of how some of the benefits that have come along with the telehealth and telemedicine being a little bit more accepted. And we were kind of forced into it during the height of the pandemic, as you mentioned, but also allowed us to recognize some of the benefits and some of the possibilities. And I agree with you. I think there are in certain circumstances for patients, if they're on, long-term, hopefully they are long-term sustained and maintained, maybe on just an oral therapy. And so at some point in their care, it might feel comfortable to say, well, let's have you come in for an in-person visit every X amount of months, but in between, let's just have a telehealth visit and check in on you. Obviously, any visit that requires, physical examination and reviewing, being with the patient face-to-face would be limited by that. But I think what we're seeing is that for patients who are through their initial therapy and in a survivorship journey, those types of visits can sometimes transition. So I think you bring up a great point that we shouldn't lose sight of some of the benefits that the telehealth can add to the care that we provide to patients, and really helps maybe overcome some of those barriers, like expense of travel. Those types of things could really be perhaps mitigated by using that strategy at the right time.
Absolutely. And, we have patients also maybe with other caregiver responsibilities, childcare, or other
Mhm.
family members they're caring for, and it makes it difficult for them to get here for that reason as well. So, yeah, I do think we are able to use it in a good way. And I think it definitely has, made care more accessible for a number of patients might have been previously inaccessible to them.
Now let's shift the conversation just slightly to immunotherapy. Can you expand a little bit on just how you see the advancements in immunotherapy? Have they impacted or expanded treatment options?
Absolutely. And I hearken back to some of my earlier days in oncology when immunotherapy was available, but in very limited forms. And when I was early in my career, we would use something like IL-2 for patients with kidney cancer, and it was interferon. And those are two old immunotherapy drugs that we had in our armamentarium back then, but they were extremely toxic,
Mhm.
and a lot of times required hospitalization. They weren't all that effective either. I think with the development of the checkpoint inhibitors, it really kind of caused an explosion in the landscape of immunotherapy. And in 2011, we saw the first FDA approval for ipilimumab, the first checkpoint inhibitor to be approved in melanoma. And then I think everybody is familiar with pembrolizumab, and that was the first anti-PD-1 checkpoint inhibitor that was approved in 2014. And I can't even tell you how many indications it has now. It was initially approved in melanoma. Now,
What's not approved for it, I think, is
exactly.
the easier question. I think the package insert's like 125 pages long or something. So, yeah, that's not a light read anymore.
No, for sure. And I think the introduction of the checkpoint inhibitors has really significantly, as far as immunotherapy goes, has really changed our treatment paradigms for many, many cancers. And I think they are contributing to why we're seeing significant improvements in cancer survival over the last couple of decades.
When I think of immunotherapies and when they first came to the scene and into my sort of realm when I was practicing at the time, what I really remember most is how it really sort of shook the foundation of what I considered typical symptoms from anti-cancer treatment. It was easy and I think good to be able to celebrate, oh, it doesn't cause all the toxicities everyone knows chemotherapy for, the nausea, the vomiting, the hair loss, things like that. It doesn't have nearly the risk of those. But then I think we quickly learned that what they do cause, the immune, related or immune mediated adverse events, are very unique and very different and equally toxic and concerning, but just their presentation and the timing is just so different from what we knew. That was, I think, in my mind, I remember internally having just this biggest shift in my thinking about now we have to kind of hold both of these things at the same time. Maybe you had similar experiences with that.
Yes, and I think that is a great point. And I think it's one that we're still dealing with in this day and age, especially whenever we have patients going to other care settings and other providers who maybe aren't as familiar with immunotherapy and are thinking about traditional chemotherapy side effects, which are more predictable. Whereas, the immunotherapy toxicities, as you mentioned, are often unpredictable and are completely different than what we would see with chemotherapy. And yeah, certainly caused a shift in our thinking about how we're following these patients and how we're thinking about toxicities and rare toxicities that may occur that we constantly have to be vigilant. I tell my patients that all the time. These are some of the common side effects that you could develop, but there can also be less common side effects, and we can't really go over every single one. But I want you to be vigilant for anything new that comes up that you weren't anticipating. And then we'll be able to look into it and see if we think it's from the cancer therapy.
And so many of the immune mediated ones, they almost mask other seemingly benign or not that serious type of side effects that I think a lot of patients might, without given specific instruction, might instinctually just kind of like, oh, it's not that big a deal. It's just a little this, it's just a little something. But those are usually the very first signs of something that will evolve into a significant side effect. It's not just diarrhea, it's going to be colitis, so I think it's, like you said, important to, empower that patient to say, if something comes up, we need to know about it. And if it's nothing, we'll work through nothing together. If it's something that we can assess and decide that this is likely nothing to be overly concerned about or unrelated, we'll work through that together. But we know you never want patients to feel like they have to do some of that like critical thinking and decision making on their own, because we're all still learning, as these treatments become more widespread.
Absolutely. And I think educating other providers in other specialty areas and the primary care setting, trying to make them a little bit more aware as we're seeing more and more patients receiving these therapies. I think it's important to kind of spread the word a little bit about these different toxicity panels that we may be seeing and other departments may be seeing.
Absolutely. And kind of back to when we talked about the setting, we talked about the physical setting of, where the patient is existing and getting this treatment, but the setting in terms of where these treatments are now being used along the disease trajectory, whether it's upfront and frontline. Originally they were, of course, coming right out of clinical trial. We were doing them on late stage patients or people with advanced or recurrent disease. But now, many disease sites have frontline treatment that includes either immunotherapy or targeted therapy or both. And that creates this new, like seemingly impossible complexity of if they're on a treatment from each of these categories, potentially at the same time or in quick succession, that how we as the nurse are able to do some of that critical thinking of like, well, what does it come from? What's causing this? And sometimes it could be more than one thing as the answer. And so again, just reinforces the situation that nurses in oncology find ourselves in now, where everything has become extremely complex. And so it's really important to, as you said, talk with patients frequently, provide that education up front, reinforce it as they come back, and just encourage them to keep that communication open as their experience, their symptoms or side effects change. The sooner they tell us what they're experiencing, the sooner we have an opportunity to identify and intervene and hopefully prevent things from escalating or getting much worse.
I also tell my patients that some of these side effects could be delayed and might even occur even after they've stopped the treatment. So I've definitely seen that in my practice where therapy has been completed, and especially for some of these immunotherapy drugs, and a couple of months later they develop a toxicity that is from the prior immunotherapy. So trying to keep that in mind as well, is that it's not like chemotherapy. Well, even chemotherapy can have some long-term toxicities, but we do have to even keep it in mind for immunotherapy that once these drugs are finished, that there still could be some long-term side effects. And since they are sort of newer drugs, we still are learning about what some of these long-term toxicities look like.
So finally, let's discuss chemotherapy. Even though the big buzz is about targeted therapies and biomarkers and immunotherapy, what advancements do you see have already occurred or maybe being explored regarding chemotherapy?
There haven't been a ton of new FDA approvals specific for chemotherapy. However, we have seen chemotherapy still used in practice, particularly in combination with some of these other novel therapies. Particularly, we see a lot of chemo immunotherapy combinations. We're seeing, traditional chemotherapy being combined with immunotherapy. And then I think one of the kind of the more exciting developments that we've seen recently are in the realm of the antibody drug conjugates, which sort of are like a targeted chemotherapy that's sort of a monoclonal antibody kind of linked to a cytotoxic agent, but it's sort of specific for that particular cancer. And so we're seeing these primarily in breast and urothelial cancers, but also just started using one of them in the realm of lung cancer. And I think, we may be seeing sort of more of these combination therapies to hit cancers in different types of growth and using different mechanisms to hopefully improve outcomes further.
Absolutely. I think the conjugate therapies, where it is sort of those two therapies attached together and working in tandem, or, not in chemotherapy, but, a similar complexity of adding in the bispecifics where it's a single drug, but it's targeting two separate things at the same time. And so it's just, I think, another great example of how we are using therapies that are coming with different mechanism of action that we weren't even in the realm of possibility when many, established nurses, seasoned nurses, when we were in school, we couldn't have been taught this because it wasn't even a reality at that time. And so I think emphasizes the importance of understanding how these drugs work, how they need to be administered. And I think obviously this latest edition of the chemotherapy and immunotherapy guidelines and recommendations for practice Do I have it on my nightstand? Maybe. I don't know. But it does. I mean, it just reinforces the need to make sure that we're keeping our resources, our references, our guidelines updated so that as things are moving so quickly, we know that we have a trusted source that we can turn to and try to learn things. But even the reality is that as soon as this has, been printed, this wonderful reference book has been printed, science keeps moving. And so it's really important to stay engaged with your profession, with your professional society, of just making sure that as new things come along, you still have, a direct connection to trying to stay on top of things.
Absolutely. And thank you for giving a plug out there for the Chemotherapy and Immunotherapy guideline book. And I did want to mention that we do update the drug tables periodically. So that's a good source for some updated information on some of these drug therapies. And also just wanted to give a little plug that I'm co-editor on, we're working on the second edition now of ONS Guide to Immunotherapy. So looking to have that out maybe in the next year or so. And that will be another source that might be useful for nurses.
Absolutely. It's exciting. It's a huge task. I was lucky enough to be one of the many authors on a small section. And so just knowing how much time it's taken for you and your other editors to just collect all of the chapters and all of the information and review it, it's a huge undertaking. So very exciting to see that finally get into print, and exciting to hear of future editions of other texts that we know are coming and will be very helpful to support nurses as they continue their practice.
Absolutely. Yes.
Well, Suzanne, as we come to the end of our episode today, we do like to ask just a few quick fire questions just to help summarize some of the big points we've talked about. So to start that off, what types of anti-neoplastic treatments do you anticipate will grow the most, maybe in the next 1 to 2 years?
I really think we're going to continue to see a growth in our targeted therapies, particularly some of the small molecules, as more and more of these molecular targets emerge. I think, the checkpoint inhibitor landscape is fairly saturated now, but we may see more indications for some of these checkpoint inhibitor drugs. I think we're hopefully going to see some expansion of CAR T. We've already seen some expansion of indications for CAR T therapy, primarily in the realm of hematologic malignancies, but there definitely is research going on in the world of solid tumors. I think we're going to see perhaps more agnostic indications for drugs, as we had talked about before, sort of not disease specific, but maybe molecular target specific. Mm-hmm. And I think perhaps some genomic engineering, there's some work being done with this CRISPR technology. And then I think just trying to figure out some of the logistics of these therapies, like how long do we keep people on them for? Is this something that somebody with metastatic disease is going to be having to be on for the rest of their lives? Or can we get away with a much shorter duration of therapy? And then also, I think we're going to learn more about supportive care for managing some of these toxicities and maybe even ways to prevent some of these toxicities.
So, nothing too big, right? That's exciting. It is exciting to think about and to know that we are in practice. We are existing now when all these exciting developments are happening. It is overwhelming, but it's also very exciting just to know that we are essentially part of history and living through this and caring for our patients through this.
Right. And I think it is most important to put it in the perspective of the individual patient. Mm-hmm. And I always think when I see a patient, and I always think back to one of my earliest patients since targeted therapies were approved, who had 2 young children, and she wanted to see them graduate from middle school and then high school and then college. And they've met all of those milestones. And mm-hmm. just to be a part of that from patient to patient, it's been quite an honor. And it's just been very rewarding to be part of this whole process.
So kind of 2 questions bundled into one. What are some ways that you think nurses can anticipate and prepare themselves and their patients for this growth? And do you have any specific recommendations in terms of training or education that nurses could use to achieve that?
We talked kind of in the beginning about how difficult it can be to stay up to date with all of these explosions of new therapies. And I think a variety of ways of staying up to date. We kind of talked about a couple of the ONS books. Other good sources, I think the National Comprehensive Cancer Network, the NCCN, they put together guidelines that they update on a regular basis, at least once a year. Some of them are updated a couple of times a year, and those have some of the newer therapies. The American Cancer Society and the National Cancer Institute are also good sources of information. And the FDA also publishes anytime a drug is approved, you can actually go to their site and find out what new drugs have been approved. And then if you want more information, you can delve into some of these other sources. And then certainly, looking to within your own institution for any programs that might be specific for some of these oncology therapies. And then certainly ONS Congress and other ONS workshops and publications that are out there.
And then finally, do you have any recommendations if we're looking for more patient-focused resources to help them learn more about these types of therapies? Do you have any recommendations for those resources?
Actually, the NCCN does have patient-specific resources. The American Cancer Society and National Cancer Institute are also great sources. We also use a lot of OncoLink in our setting for patient education materials, and that's another, I think, good source for patients. And, obviously looking to their healthcare providers, especially oncology nurses, as being some of their trusted individuals. And then there also are actually organizations specific for somebody who has a specific mutation. There are actually groups like social media sites that post updated information about different therapeutics that could be sources of information as well, as long as they're properly vetted.
Yeah, I think that we're seeing is sometimes there are some grassroots patient sort of originated groups like that, support groups or just kind of communities that are kind of banding around a shared experience. And so can be great for patients, but I do agree with you. It's important, I think, for nurses to at least understand kind of who makes up that group and where their information is coming from. And then just also, talk with your patients if they hear things or learning things from those groups, to just talk with their healthcare team about that, to understand we can help make sense of what sounds too good to be true. Sometimes it is, and sometimes it's not, but we can be that trusted source to help kind of pick through what that information is and what it means, but a great resource for patients to feel like they have that community.
Absolutely. Especially for rare cancers, right, where patients can feel very isolated and, may actually also be able to access different trials through those sites also.
Well, Suzanne, thank you again for sharing all of your comments and your insight. It has been really great talking with you today. Do you have any final comments to share with our listeners?
As I mentioned, I've been an oncology nurse for over 30 years, and I think oncology nurses are just the most passionate nurses out there, and we would do anything with our patients. It's been quite a pleasure to be part of this world of oncology nursing.
Thank you so much.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.